Hello, colleagues again. Dear colleagues, thank you so much for your time, for your participation in this webinar today. I am Lesia Tonkanok. I'm Program Manager of European Coalition for TB. And today I am going to moderate this event together with my colleagues, Oksana Rukshenyana, Master of Public Health, who is a co-founder of the National Association of for TB patients in Moldova, SMIT. This is the TB society in Moldova. SMIT works to expand comprehensive approach, providing to treatment of TB, as well as providing mental health support and fighting stigma. And also, my colleague from Tajikistan, Mr. Ushratov, this is the organization that works in Tajikistan since 2012 working to counteract TB. Before we start this event, I would like to tell you that today at our webinar, we offer simultaneous interpretation, so it's going to be English and Russian. Detailed instructions, guidelines, how to choose the interpretation channel, you can see them in the chat, and also you can choose the language version of the slides, but we will give you more instructions, details later, a bit later before we start our presentation. Meanwhile, I'm very happy to pass the floor to Oksana Rukshenyano and to Shadmon, to my colleagues, and I wish us all a nice and productive event. Thank you so much, Lesia. Above all, on behalf of Moldova, I would like to express gratitude to our colleagues who have joined. And also, let me say that here we have colleagues from Tajikistan. This event, I hope and I'm sure that it's going to be a very good experience in the framework of this work. We will find out a lot of new things from Dr. Jennifer Purin. And let me pass the floor to our national coordinator for TB in Moldova, Ms. Valentina, who is the Master of Public Health doctor, TB doctor of the highest category, and the coordinator of the National TB program in Moldova. Her work includes planning and coordination of methodological and advisory support in Moldova at different levels, and analysis of TB activities nationally, as well as active participation and interaction with international organizations, including WHO. So, Valentina, the floor is yours. Thank you, Oksana. Thank you for this introduction. Hello, colleagues. So now it is our kind of routine to meet on the monthly basis, which is so good. And I would like to express gratitude not only on my behalf, but also on behalf of TB doctors and physiopulmonologists, not only physiatricians, because now we see that a lot of colleagues in Moldova, NGOs, and public authorities are very grateful to TB Coalition. This is the platform where doctors, professionals, and NGOs can meet, and as well as any other stakeholders, those who are engaged in TB response in Moldova. Let me mention this. This webinar is now very timely, very relevant, and let me explain why. And as I said, this is a great coincidence because we first started in Moldova with short treatment regimens, MSTR. Maybe you remember that large regional project that was back in September 2020. Just a couple of figures to explain why I say that it is so good that now we have this webinar, and Dr. Jennifer is with us and she's ready to share the experience that's so important for us. So for several years now, we have been implementing or using short regimens, MSTR, just one figure. While in 2021, we had about 20% covered by short regimens. In 2024, it is already 67%. Now it is even higher because apart from MSTR, starting from February 2024, we've been using BPO and BPO-M as a program routine management. It has been implemented in national clinical protocols. And me and my colleagues, we believe it is very timely, this webinar. Why? Because now in Moldova, we have revised our national clinical protocols and all the recent regimens that have been suggested by WHO, all of them are now included into our clinical protocols. Now we are holding trainings for our TB doctors, and 4 rounds of trainings, 2-day trainings have been held. They are our colleagues I introduced to a short regimens plus BPOL and BPOL-M. And yesterday we completed the 4th course. Next week it's going to be another one, also a 2-day course. And there we emphasize on short regimens. And we asked all of the colleagues, TB doctors from Moldova, to join this discussion because that's why it is timely, because everything that we're implementing now, this is so positive for all of us. So we are very grateful to TB Coalition, thanks to WHO for MSTR initiative back in 2020, because basically it was the kind of preparatory step where the countries were ready to implement at the programmatic level the short regimens. And of course, we would never manage without support from the Global Fund and NGOs. So this is what we refer to as MOF, and this is our approach to teamwork. And thank you so much to TB Coalition. Thank you, Jennifer. We are very grateful to you because this is so timely for us, and we will be happy to hear you and ask questions if there are any outstanding questions. So every success to all of us, and I believe that soon there will be another discussion on these topics. Thank you. Thank you, Valentina. Now, Shadmon, the floor is yours. Thank you so much, Lisa. Hello, colleagues, dear participants. I am Shadmon Kushvahtov. I work in Tajikistan, and I'm very happy to welcome everyone who has joined today our international awareness raising online event. And we are so happy to see among our participants, well, I see here representatives of different countries and TB doctors, immunologists, and representatives of the educational sector, NGOs, as well as members of communities, affected communities. Colleagues, can you hear me well? Because I heard some voice in the background. Okay, great. So let me note that today's webinar is focused on one of the priority topics for the healthcare system, and that is about innovations, short or oral regimens for treatment of MDR-TB and possible side effects. We are confident that today's webinar, hopefully, that it will be the platform for exchange of knowledge and experience, and that will help improve the quality of medical services, healthcare services in the future for us to implement our national indicators and national programs. I would also like to note another important aspect today. We will hear how clinical recommendations, both clinical recommendations from leading international experts, and also we will hear personal experience of people who underwent treatment, and that makes this discussion especially valuable. Also, I would like to note that now we are all here holding this meeting in the conference room of the National TB Program of the Municipal TB Center. Here I have colleagues, doctors with me, and patients as well, those who are ready to share their stories of TB treatment, and that's very valuable for us today. I also would like to express gratitude to the director of the Municipal TB Center for his support for this opportunity, and of course that once again emphasizes how significant this event is for us. So thank you all to all the participants. Thanks for your contributions. Thanks for your interest in this topic of combating TB, and wish us all fruitful exchange, fruitful work. As mentioned by our colleagues, this is just the beginning, and further on, we look forward to our joint work with the team. So I wish us all productive, helpful work and exchange today. Thank you. Shall I pass the floor further, or maybe you do that? Okay, thank you. Thank you, Shadmon. And we pass the floor for welcome address to Dr. Okhtam Bukhachev. Hello, it's evening here, so good evening. And I see that you can hear me. And I also would like to welcome the participants. I see this is 85 people, and that's about significant adherence. And well, that's about that we need this kind of discussions. COVID taught us a lot. Now we are used to online discussions. Previously, we preferred offline meetings, but happily now with digital technologies, it is possible to have these fruitful events. I will not repeat everything that was said by colleagues from Moldova. Let me just mention that recently we completed our desktop analysis, and we could see a lot of obstacles on the path of implementation of the program. Doctors say that correct diagnosis is 50% of treatment, but when you see barriers and obstacles, that's also an important part, step on the path towards success. So we try to develop short-term, mid-term, and long-term activities to address all of those issues. And I hope that we will achieve a lot of positive results. But now we have this problem. And even though we may lack some statistics, if we compare with WHO indicators, but the efforts in countries, including Tajikistan, are being made, and we see the adherence, readiness, commitment of doctors. We see engagement of those patients who have recovered and who want to help other patients to go through this trial. And well, now winter is coming, and we have problems with electricity, and that has a significant impact on logistics sustainability of the program. Also, it impacts internet connection and delivery and timely implementation of the components. And of course, there is also the issue of lack of funding. We are working on that as well. There are problems regarding stigma and discrimination, mostly in rural areas. And that is another component where we are making a lot of effort. And also, I'd like to mention that in Tajikistan as well as in Moldova, I know that there are no problems with the access to medication due to development partners, due to budget financing, state budget financing. We see that there is almost no logistic issue. I mean, access is provided for patients in all the regions, and they have access to treatments, including what they need for treatment of MDR TB. I also agree that today's discussion is going to be fruitful, and exchange of experience, exchange of knowledge, of impressions, that's so helpful for all of our parties. Thank you for your attention, and we are ready to actively engage and participate. Thank you. Thank you, colleagues. And dear colleagues and Dr. Will, Dr. Babakhajayev, teams from Moldova and Tajikistan, thank you for this warm address. And now, traditionally, this is time for a family photo for us to kind of document everyone here so that we would had good memories. Now, if it is possible for you, please switch on your cameras and we will try to make photos. It may take a couple of minutes because that's many of us, right? 88 now. So we need to make sure that we take a photo of all the entire group. I see my colleagues. Please, colleagues, tell us when we are ready. You see, 88 participants, it takes time. That's a great team from Tajikistan. Yeah, Lisa, let me just add that there are many more participants, right? You can see that. All the portraits are ready. Okay, we are ready to proceed. Thank you so much, colleagues, and we can proceed. And definitely we will send you all the materials of this meeting today. We will present them to the participants who registered for the meeting. Now I want to use this opportunity and once again welcome you to our today's webinar on short regimens of TB treatment and side effects. So adverse events management. At the end of the webinar, we will have a Q&A session. So we ask you to keep your questions a little bit back and ask them after the end of the presentation, or you can write your questions in the chat and we will definitely address them during our Q&A session. During the presentation, we ask you to mute yourselves and please try not to share your screens, not to interfere. Before we proceed with our main presentation from Dr. Furin, short guidelines on how to follow the presentation in the language that is more convenient for you, either English or Ukrainian. So you can follow the audio channel and you can also watch the slides, see the slides in the respective language. So you can choose the screen that is more convenient for you. So it's going to be the presentation in Russian or the screen by Dr. Jennifer Purin. She will show the English version of the slides. And again, the step-by-step guideline can be found in the chat. And now I'm so happy to pass the floor to Jennifer Purin, Doctor of Medicine, PhD, clinicist, infectionist, and medical anthropologist, the Director for Development of Clinical Potential in the framework of the project on combating DR TB for children. The floor is yours.
Great. Well, thank you so much, Lesia, and thank you to our esteemed colleagues for the introduction. It's really a great pleasure and honor to be with all of you I am a TB doctor. I have worked for 30 years on drug-resistant TB. I've actually had the great pleasure of working in some of the countries that you all are coming from. I spent several months, in fact, in Machiton Hospital, where I learned a great deal from my colleagues in Tajikistan. So it's wonderful to see many of you here. I know that these are very challenging times, both in the TB space and globally. I recognize that the country that I live in is contributing to a lot of that, and I'm very sorry for what we're putting people through. And it gives me just a great deal of admiration for those of you who continue to do this really challenging work on tuberculosis every day. So in the spirit of that, I'd like to talk a little bit about some of the exciting things that are happening in terms of all oral shorter regimens for drug-resistant TB. So just by way of disclosures, I have received support from the Stop TB Partnership to support the rollout of pediatric formulations of many of the second-line drugs. And then for today, there's a lot to cover, but what I wanted to do was really review the WHO recommendations that came out in 2025 and the evidence that went into supporting some of those recommendations, where those recommendations now include a number of options for people with drug-resistant TB for treatment with all oral shorter regimens. So I think the bulk of this webinar, we're going to spend talking about some of the side effects of these regimens. I think for those of us who are older doctors or who've been working on drug-resistant TB for a long time, we think that these regimens are much better compared to the old regimens we used to use, which lasted for 18 to 24 months and included a lot of drugs that caused many side effects. So these new regimens are wonderful, but I think we have to remember that for many of the people who come to us seeking care and people who are diagnosed with drug-resistant TB, these regimens are still long, they're still complicated, and they still cause multiple side effects. So we want to talk about those and how to approach thinking about those, monitoring those, and managing those. And then just to talk about some action points, both for impacted communities and community members, as well as the organizations and providers who are caring for people with drug-resistant TB, so that we have something to follow up on. So I do really want to acknowledge that these are very exciting times in drug-resistant TB. I think for the first time ever, a majority of people who are diagnosed with this disease can now be treated with all oral shorter regimens. And I think for many of us, this was a dream, right? We didn't think we would see this in our lives or careers. So it's very exciting. And there are actually multiple options that exist that are appropriate for most populations. And I think that's a nice, exciting update in the 2025 WHO guidelines. But again, as I mentioned, although these regimens have resulted in markedly improved outcomes and much less toxicity, they're still long and they're still associated with notable adverse events. So making sure that we monitor for those and provide support around those is a key part of the work that most of us do as TB clinicians, programs, civil society, and supporting organizations. So the WHO recommendations that came out in 2025 were a little bit long, and I apologize especially to the people who are doing the translation for this part, because there's a number of complex words in here. But the WHO essentially, prior to 2025, the recommendation was for BPAL or BPALM. And we know that there were some people who couldn't get that regimen, particularly children under the age of 14 and pregnant women. So in 2025, the WHO convened a guideline development group to review several other randomized control trials that were done to provide evidence on other all oral shorter regimens. And the good news is the WHO came out with recommendations for 4 of these regimens. So they recommend or they suggest the use of a 6-month regimen, and this regimen contains bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine. And this regimen is recommended for people whose strains of TB have either susceptibility or resistance to the fluoroquinolone. And this recommendation included children, adolescents, pregnant, and breastfeeding women. So I think that was a key recommendation that came from the WHO. So this is a second 6-month regimen. The WHO also recommended the use of 3 9-month regimens. And these regimens contain various combinations of drugs. So the first one is bedaquiline, linezolid, moxifloxacin, and pyrazinamide. The second is bedaquiline, linezolid, levofloxacin, clofazimine, and pyrazinamide. And the third was bedaquiline, delamanid, linezolid, levofloxacin, and pyrazinamide. So these regimens are recommended for people whose strains of TB do not have fluoroquinolone resistance. And the WHO gave those regimens an order based on pill burden. So we're going to get into the details on that. So basically, the WHO 2025 guidelines suggest that a majority of people be treated with the BPALM regimen. But for people who cannot get the BPALM regimen, they did recommend these other options. So we're going to take a little bit of a deeper dive into the evidence behind these new recommendations for 2025. So I'm not going to review the evidence for the BPALM regimen, but rather I'm going to talk a little bit about the evidence for these other regimens. So as you can see here, this is just a schematic showing the components of the 6 all-oral shorter regimens that WHO now recommends. And I think the key here is that all of those regimens contain bedaquiline, linezolid, and a 3rd-generation fluoroquinolone, and then the rest of the regimen composition varies. So the first regimen that the WHO recommended in addition to BPALM is something that's called or referred to, a lot of people, you'll hear them talk about the beat tuberculosis regimen. So this is the 6-month regimen that consists of bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine. And this recommendation came from a trial that was called the Beat Tuberculosis Trial. This trial was done in South Africa, and it was only done in South Africa. And so it was a trial that randomized participants to the 6-month regimen that I mentioned, or to the 9-month standard of care regimen in South Africa. So at the time in South Africa, they were using a modified 9-month regimen. And so they compared the 2 regimens to each other. So what they found, they randomized a total actually of 404 participants. But what went into the WHO guidelines was an interim analysis based on 374 participants. And what they found was that the experimental regimen, so it's that 6-month regimen of bedaquiline, delamanid, linezolid, clofazimine, and levofloxacin. What they found is this regimen worked just as well, or in science speak, it was non-inferior to the 9-month regimen. So both regimens resulted in an 86% treatment success rate, so excellent results. And that the shorter 6-month regimen was just as safe as the standard of care regimen. So this data was presented to the WHO, and this is what led to the recommendation of the alternative 6-month regimen. So what's exciting about the Beat Tuberculosis trial is that they did include children in the trial, and they did include pregnant and breastfeeding women. So that is how the WHO was able to make this recommendation and to extend this recommendation to people of all ages and to people who are pregnant or breastfeeding. And then the other nice thing about this trial is that it starts with 5 drugs, but if you have results for fluoroquinolone resistance, you can drop one of the drugs. So if there's susceptibility to the quinolone, you can drop clofazimine. And if there's resistance to the fluoroquinolone, you can drop the levofloxacin. And if you don't know, then you keep all 5. So this study hasn't been published yet, but we're hopeful that we'll see the publication in 2026. So the second trial that went into the WHO recommendations that came out in 2025 was a study that was called the End TB trial. This was a really interesting trial. It was done in multiple countries around the world, and it was also a non-inferiority trial. And what they did is they used something called adaptive randomization, where they actually had 5 different regimens and a standard of care arm where they could randomize people to each of these regimens. And then if one of the regimens looked like it wasn't performing well, they could stop randomizing to that regimen. And so unlike other trials, which were trying to find one regimen, the END-TB trial wanted to identify as many regimens as possible that were non-inferior to the standard of care. So when this trial was being designed back in 2010, things were very different in drug-resistant TB. So the teams felt that they wanted to give as many regimens a chance as possible. So they went for 9-month duration instead of 6 months. And all of the regimens contained pyrazinamide. And this was because it's thought that pyrazinamide might have a synergistic effect with many of the agents, in particular bedaquiline. So all of the regimens last 9 months, all of them contained pyrazinamide. And then the rest of the regimens they tested were different combinations of bedaquiline, delaminid, linezolid, a 3rd-generation fluoroquinolone, and or clofazimine. So it was a complex trial. And what they did was for each of these regimens, they compared them to the locally accepted standard of care. The standard of care could change during the course of the trial, as we know that it often did. And so these are the results for the different regimens that they tested. You can see of the 5 different regimens, the first 3 had the highest rates of treatment success. And that compared with the standard of care or the control arm, the first 3 regimens were found to be non-inferior. So that's where the next 3 regimens that are recommended by the WHO come from. It's from the NTB trial, and it's the 3 regimens that were found to be non-inferior or the same as standard of care. Okay, so the WHO basically took a look at all of these regimens, and even though none of the studies compared them to each other, the WHO decided that they would rank order the recommendations based on duration, pill burden, and then cost. So when you look at the WHO recommendations, they do give an order to those regimens, but it's important to remember that none of those regimens were compared to each other. But this has left, it's exciting to have options, right? But this has left a lot of people wondering, well, how do I know which regimen to give? And what we're telling providers and what most of us who care for patients do is we look at our individual patient, what their drug susceptibility test results show. And then we consider sort of their age, any toxicities they might have, where their disease might be before we come up with the recommendation. It's important to remember that people with meningitis, people with TB in the bone and the joints, so osteoarticular disease, they can't get these regimens. And that's because these patients, even if they have drug susceptible TB, require 12 months of treatment. And that people who've had previous treatment using the drugs in these regimens, so if someone got bedaquiline previously or linezolid, we really don't recommend these regimens unless you can confirm susceptibility to those drugs. And then again, it's important to remember that children under the age of 14 and women who are pregnant cannot get pratominid, right? And that's because pratominid is associated with reproductive toxicity in animals. We don't yet know how to dose it in children. So you can't give BPALM, right, to people who are pregnant or children under the age of 14 years. So the way that it works in most countries is right now, everybody who's over the age of 14, who doesn't have a pregnancy and who hasn't been treated with these drugs previously or have TB in the bone, the joints, or the meninges, they get BPALM. Okay, and then everybody else either gets the 6-month regimen from the beat tuberculosis trial or one of the 3 NTB regimens. We do know the NTB trial was a really well done trial. So some countries say, well, those studies, that was a better study than the other studies. So we're going to give those regimens a little more weight. But also drug availability and pricing drives a lot of the decisions. So for example, delaminid can be expensive and difficult to get. So some countries are choosing the 9-month regimen that contains bedaquiline, linezolid, moxifloxacin, and pyrazinamide. But it is important to remember that, especially for children and pregnant women, that delaminid-containing regimens are very well tolerated, and that there are pediatric formulations. So to summarize, this is a very busy slide, and it's the next 3 slides, so I apologize. But we put together a table for programs, for clinicians, for civil society impacted communities that compares each of these regimens in terms of the duration, the pill burden, the side effects, any resistance testing that needs to be done at baseline, what kind of monitoring that needs to be done, consideration in special populations, so that people can see sort of what's out there and what things might affect which regimen you choose. I want to mention specifically, because it was brought up by Valentina at the beginning, you'll see that the modified STR that many countries that in your region were using starting in 2020 is not on this list, and it's not formally recommended by the WHO. And that's because that evidence wasn't submitted yet for consideration in recommendations. So it's not that there's anything wrong with that regimen, and some countries are continuing to use that regimen. It's just we don't yet have a WHO recommendation there. So I would suggest, colleagues, we can distribute this table rather than go through the slide, because it's very busy. And then if there are questions or comments that still come out from that table, I'm happy to take them over email. So again, it goes through each of the regimens and compares them on those topics. So I want to switch gears a little bit, though, and really talk about toxicity, because even though these regimens are shorter, and even though they're much better than the older regimens we used to use, things that had amikacin that made so many people lose their hearing, or PAS or ethionamide that caused so much GI distress, these are still regimens that contain medications that cause side effects. And they're still relatively long. 6-9 months is not a short period of time. It's shorter than 18 to 24 months. But again, we have to remember, hopefully most people coming to us for DRTB care don't know those older, more difficult regimens. So we did think about the person who's sitting there now, that this is a long regimen, and that we have to really approach this in a thoughtful way. And as most of us who do DRTB care know, a majority of our time is spent monitoring for and managing side effects. So it's something we should do well. So I think our old approach used to be that we didn't really want to talk about side effects, that we didn't want to tell people about side effects because we were afraid if we told them that they wouldn't agree to treatment, right? But I was working in 2010 with some patients, and someone said to me, I don't understand why you doctors won't talk about side effects. These are our bodies, right? These things are happening to us. Do you think we're not going to notice, right? So I think there has to be a lot of shifting now in thinking about active partnership, right, with people who have drug-resistant TB, and that there are partners in care. So we have to talk about this, and there's data from multiple studies that show improved communication and exchange of information between providers and people receiving care. It actually results in improved outcomes. So I just want to put that plug in there, because I know many of us, we get nervous talking about side effects, but it's something that we need to do. So I want to talk about the different side effects that we can expect with many of the drugs that are common in all of the regimens that are now recommended by the WHO, so that we can prepare people who are receiving these regimens, and we can think about how we monitor for these side effects so that we can avoid them and minimize them. So the first drug I want to talk about is bedaquiline. Bedaquiline is a great drug. It's one of the drugs that has really changed the landscape for drug-resistant TB.
И это то, что изменило
Am I going too
Sorry.
fast?
No, sorry.
Oh,
Just
no, that's okay. Yeah, sorry. Um, so bedaquiline is a strange drug, though. You have to give a loading dose of bedaquiline, and it sticks around for a long time. So around 6 months after you stop taking bedaquiline. So it's a little bit of a strange drug in terms of how it's dosed. And the main side effect of bedaquiline is prolongation of the QT interval. So prolongation of the QT interval in and of itself is not a problem, but what happens when the QT interval is prolonged is that there's a risk for cardiac arrhythmias, right? So this is something bedaquiline causes the QT interval to prolong, and it's really important that providers are aware of this because most patients don't have symptoms when their QT interval is prolonged. Bedaquiline also does have some drug-drug interactions, particularly with rifampicin and efavirenz. So efavirenz is a drug that's used to treat HIV, although not as commonly anymore. Bedaquiline tends to accumulate in the fat tissue, so in the adipose tissue. And so we do see bedaquiline in the breast milk with women who are breastfeeding. So it's something to keep in mind as well. We still use bedaquiline, but it's just something for people to be aware of. So I mentioned that the main side effect of bedaquiline is QT prolongation, but it's important to remember that most people with QT prolongation are asymptomatic. So patients and people living with the disease, they won't notice this and they won't report this. Although some people might have some issues with dizziness or chest pain or fainting. But because this QT prolongation is silent, it's really important that we look for this in a standard way. So before starting treatment, all people who are going to receive bedaquiline should have a baseline electrocardiogram. And then we should check these routinely. In some countries, they do this every month, but really every month is probably a little bit too often. Studies have shown that if you check at baseline month 1 and month 3, that's fine. But you can check more frequently in people who have cardiac issues or who are on other medications that prolong the QT interval. And most QT prolongation occurs by week 12. So there's not really a risk of cumulative toxicity. If you need to increase bedaquiline beyond 6 months, there's no increased risk there. So it's just something to remember. So linezolid is the other drug that really revolutionized treatment of drug-resistant TB. So you'll see it's part of the all-oral shorter regimen. So there's no single all-oral shorter regimen that doesn't contain bedaquiline and linezolid. The issue with linezolid, though, is currently this is our most toxic drug. This is a drug that's hardest for people who are on treatment and causes the most problems. So linezolid actually tends to cause 2 different categories of problems, and they appear at different times. So early toxicity seen with linezolid tends to manifest as bone marrow suppression. So these are patients who will come in with anemia, thrombocytopenia, leukopenia, and this tends to occur usually right away after taking linezolid, but we tend to see it happen before 12 weeks of treatment. And then you can also see lactic acidosis in patients on linezolid as well. And then linezolid tends to cause some later toxicities. So these are toxicities that tend to develop after 8 weeks on the drug. And these tend to be more nerve-related toxicities and include optic neuritis and peripheral neuropathy. So these are things that tend to occur after week 12. And what you'll see is that early on, patients who are having bone marrow suppression, they often present with symptoms of anemia or thrombocytopenia. So they're fatigued, they're dizzy, they may report easy bruising or nosebleeds. And then patients who have the later toxicities, they'll develop symptoms associated with the optic neuritis or peripheral neuropathy. They may say their vision is blurry. They may report problems like I can't tell the difference between colors anymore. And then the patients with neuropathy, it's often burning or numbness or tingling, and it usually starts in the hands and the feet first. These are where the nerves are the longest and tend to develop the problems first. What's interesting about linezolid toxicity is it tends to be related to the trough or the lowest concentrations. And so you'll see in many of the trials, they actually did a linezolid dose reduction to try to minimize the toxicities. And so in BPALM and the NTB trials, what they did was after 16 weeks, everybody got their linezolid dose lowered. And then in the BEAT tuberculosis trial, they lowered the doses depending on symptoms. So that's just something to keep in mind. So the other thing about linezolid is there's often overlapping toxicity, right? So we'll see if patients have HIV and they're on AZT, that can also cause bone marrow suppression. And then linezolid has overlapping toxicities with alcohol. And a lot of our patients do consume alcohol. So it's just something to mention. And that we actually see more linezolid toxicity in people who are living with HIV and in people who are living with diabetes as well. It's also important to mention that linezolid can have overlapping toxicity with mental health medications, in particularly people who are on antidepressants. Linezolid can cause more toxicity. So these are just things to be aware of. We have to do frequent and routine monitoring for all patients who are receiving linezolid, because by the time they develop symptoms, it's often too late to reverse those symptoms. So linezolid is a nice drug in that if you identify the toxicity early and either change the dose or hold the drug, those toxicities are usually reversible. But if we wait until it's too late in the course of treatment, those toxicities may be permanent. So monitoring patients in the absence of symptoms is really important. So making sure everybody prior to starting treatment has visual acuity checked, and that their color vision is checked, that we get a baseline and a monthly complete blood count, and that we do formal testing for peripheral neuropathy. So this should be done at baseline to document the level that exists prior to starting treatment, and then every single month on treatment, regardless of the symptoms, regardless of what else is going on. Okay, so that has to be done. And then if we notice that there's a problem like the blood counts are dropping or the person develops neuropathy, then what we usually do is we hold the linezolid for a little while, or we lower the dose from 600 milligrams to either 300 milligrams a day or 600 milligrams every other day. And this is a good way to manage linezolid toxicity. So most of the regimens contain either levofloxacin or moxifloxacin. These drugs are very well tolerated. The main side effect of levofloxacin is myalgia, arthralgia. Some patients might get a little bit of confusion. Very, very rarely people develop rupture of the Achilles tendon, and this can cause a little bit of QT prolongation. There's no specific levofloxacin monitoring that's needed. All the monitoring for these regimens that's happening is fine for levofloxacin. And we can usually, if patients develop some of those joint or muscle problems, we can usually manage those symptomatically. And moxifloxacin has a very similar profile. The one issue to bring up, though, is that moxifloxacin does tend to cause more of that QT prolongation. So in patients who are in regimens of bedaquiline and moxifloxacin, so like the BPALM regimen, you may want to consider doing ECGs every month instead of at month 1 and month 3. So the next drug that's common to several of these regimens is clofazimine. And so I want to mention clofazimine for a couple of reasons. It's a drug that can cause problems for patients. Clofazimine is a drug that's concentrated also in the adipose or the fat tissue. So you will see it in breast milk, and women who are breastfeeding on clofazimine may report that their breast milk is a different color. Because the main side effect from clofazimine is skin hyperpigmentation. So people will report that their skin changes colors, and you'll notice this, right? And when I was first starting as a doctor for drug-resistant TB, we would say we know who's taking their clofazimine if their skin changes colors. So we're using lower doses now, but almost everyone will notice that their skin changes colors and that this will last for several months, even after treatment is stopped. Okay, so it's important to remember that because clofazimine hangs out in the fat tissue, it'll take a little while for the hyperpigmentation to resolve. The reason that this is important is that this cosmetic change can be very upsetting to people. In particular, it can lead to inadvertent disclosure, right? So people will notice that the skin is changing colors and they'll ask, what's wrong with you, right? In some settings, people know about clofazimine, and so this can be a way that TB status is disclosed without someone telling them. And there can be a lot of stigma associated with the skin color changes. I remember when I was working in Tajikistan, this was especially challenging for young women. Many of them had partners who were working outside of Tajikistan. They would come home, they would see the skin color changed, and this led to some really serious challenges. So the young women we were working with, they really hated being on clofazimine. And it's just important to discuss this and counsel people about this and help people strategize about this. So clofazimine will also cause QT prolongation. So you've heard this for a few of the drugs that are there. So it's just important to monitor those ECGs. And then clofazimine can also cause nausea, vomiting, and abdominal pain. Nausea and vomiting are really hard for people who are undergoing treatment. I think sometimes as providers, we tend to minimize that and say, oh, it's not that big a deal, but it is for people who are taking treatment. So thinking about that and how to manage that is really important. And then everyone on clofazimine will need the ECG monitoring, both baseline and monthly, symptomatic management, and then ongoing counseling and support around the skin color changes. So delaminid is another drug that's common in some of the regimens that are now recommended, particularly the beet tuberculosis regimen and some of the NTB regimens. This drug is relatively well tolerated. It can cause some mild QT prolongation, but its main side effects are central nervous system side effects. So we'll see often in children that there's reports that they're having nightmares or strange dreams. There may be hallucinations reported, depression, and so this is something to make people aware of. This is an overlapping toxicity with taururzidone or cycloserine, whichever of those drugs you're using, but also with alcohol and other psychoactive substances. So all people on delaminid-containing regimens will need to undergo baseline and monthly screening for depression, anxiety, mental health conditions. And this should also be done at every visit. And then just making sure there's ongoing counseling and psychosocial support. So pratominid, this is a drug that's in the BPALM and BPAL regimens. So this drug has actually only ever been tested in combination. So we're not really sure what the side effects are, although we think it's a relatively safe drug. I think the key with pratominid is that in studies where it was used in combination with pyrazinamide, there were really high rates of hepatotoxicity that were seen. So in fact, some of the early studies where pratominid was given with pyrazinamide for drug-susceptible TB, those studies were stopped because there were multiple patients that developed fulminant hepatic failure. So it's just something to keep in mind. We don't see this as much in patients with drug-resistant TB, but you may want to be more careful with liver function monitoring in patients who are on pratominid if they have hepatitis C, if they're using alcohol, if they've had hepatotoxicity in the past. And this degree of hepatotoxicity, again, the sooner we pick it up, the better. So we recommend baseline liver function and monthly liver function testing. But if a person who's receiving treatment comes in and says, oh, my skin looks more yellow or my eyes look more yellow, it's really important to remember this could be a late presenting sign of hepatotoxicity. We also know that pratominid in animals was associated with the development of cataracts. We haven't seen this in humans, but it's just something else to keep in mind. And then one of the other toxicities that was seen in animals with pratominid was testicular toxicity. So that's why this drug is not given during pregnancy or to people under the age of 14. So we're hoping to have more safety data in younger people and dosing data in children on pratominid in the coming years. But just to mention, that's why we don't give pratominid or BPALM to children or pregnant people. One other thing to keep in mind is that we should not really ever give protominid with pyrazinamide, just because of the hepatotoxicity. And then I just want to mention pyrazinamide because it is a component of all of the end TB regimens. So if you're using those 9-month regimens that are recommended by the WHO, pyrazinamide is in all of them. So keep this in mind. The primary side effect of pyrazinamide is liver toxicity, and this is especially associated with higher doses. But pyrazinamide can also cause arthralgia and arthritis. So there is overlapping toxicity when pyrazinamide is taken with alcohol, which we know is a problem for many of our patients, and that some of the liver toxicity can present as nausea, vomiting, abdominal pain, changes in the eye or skin color. So if you have someone who's on pyrazinamide, we do recommend routine monitoring of the liver function, both at baseline and then monthly. Some people for the arthritis or arthralgias will check uric acid, but you don't need to do that. And we generally tend to just do symptom-directed monitoring in patients on pyrazinamide and then avoid using this drug with protominid. So I didn't talk about all of the drugs, but just the drugs that are part of these all oral shorter regimens. And again, I think the key is partnership with people who are receiving treatment, baseline monitoring, and then routine monitoring for something, but also symptom-directed monitoring depending on the symptoms people might have. It's really important that we do a better job documenting adverse events in people's medical records, both so that we can follow that clinically, but also so that later if people want to go back and look at how often toxicity developed, that's put in there in the medical record. And then also for adverse events that lead to hospitalization, that lead to death, or that are severe, that we report these right to our national authorities as part of active pharmacovigilance, so that countries can keep an eye on how people are doing in terms of toxicity. But I think the key is we really have to think about managing side effects, right? It's not just about reporting side effects or recording side effects, but it's managing side effects, because side effects make treatment really hard. And we know that even though these regimens are shorter, they're still challenging for people to take. So the more that we can partner with people who are receiving treatment to manage their side effects, to come up with ways to minimize the impact of those side effects on their daily lives, the better. And that, monitoring and management of adverse events should be done as a routine part of DRTB care, and people shouldn't have to pay for these services. So just a shout out, or to briefly mention this term, active drug safety monitoring and management, or ADSM. This is a concept and a term that was introduced really back in 2015 and 2016 in most settings when we were rolling out the newer drugs, bedaquiline and delaminid. And the WHO does have recommendations around this. So it's a routine part of DRTB care, where we systematically look for and manage side effects, and then we systematically report those through active pharmacovigilance systems, either in the country, most countries have these systems, or you can report more globally to the World Health Organization. This helps us better understand the safety of medications overall, and to identify any problems. Sometimes there's problems that occur with the manufacture of medications. There may be batch quality issues. And so it's important that we monitor trends, because sometimes we can see challenges that come up. So thinking about not just your individual patient, but the overall patient populations in your country and globally. So that's what ADSM, or active drug safety monitoring and management, is. Okay, so there are some, I think, key action points for impacted communities and for civil society, and really even for providers to think about. And I just want to mention these because it's been a little bit of a dense webinar. So the key is really, we have to know which tests should be conducted at which visit, right? So all of us really should have checklists, right, that we look at baseline. Before I start somebody on treatment, these are the tests that should be expected. These are the tests that should be done at month 1, month 2, month 3, month 4, and really, again, working in partnership. I think providers, impacted communities, and civil society, we can really help remind each other, right? Hey, I didn't get my EKG today, my ECG done today. It's month 1, this should be done. And then, oh yeah, let's get that done today, right? So at baseline, everybody should be getting a blood draw. That should be sent for a complete blood count, liver function testing. Everybody should get an ECG. Everybody should have their vision tested formally, their peripheral nerves tested formally. Everyone should have standard screening for depression, anxiety. All women should be tested for pregnancy if they're of childbearing age. And then we really should be making sure our patients are tested for HIV and hepatitis so we can co-manage these conditions. And then there's routine testing, right? Everybody on linezolid needs a blood draw every month to test for a complete blood count. Everybody should have their vision tested, their peripheral nerves tested, and then have standard screening for mental health issues. Everybody should be having at month 1 an ECG, and then possibly at month 3, although if they're on multiple QT prolonging drugs, which most of these regimens contain multiple QT prolonging drugs, monthly ECGs should be done. And everybody should be aware of this, right? And then for people who have symptoms, right, there are certain tests that should be done as well. If someone comes in at month 1 and they're complaining of nausea and vomiting and their eyes look a little bit yellow, that is a symptom that should prompt us to test liver function, right? So there is symptom-directed monitoring that we should do. Sometimes TB can cause people to feel weak, tired. They'll have symptoms such as cough and weight loss, and it can be a little bit challenging, especially for the person who's receiving care, to know, is this due to TB? Is this a side effect? Like, what should be happening in my body? And it's important for us to think about and talk about that. What we should expect is that over time, people will feel better. And over time, those symptoms that are related to TB will be getting better, right? These are really good regimens. They're really potent. So if those symptoms aren't getting better, if people aren't feeling better, then maybe the symptoms are related to a drug, right? And we know that over time, most of the symptoms that are happening are due to drug toxicity and not TB. So this is one of the things that I talk about when I'm providing care, is that if you have something that is new to you or something that's getting worse with treatment, that may be a side effect, and we need to think about and run some tests for that. Again, the key, I think, to remember is that medication side effects can be managed better if we find them early. So we need to encourage people, tell us if you're having symptoms, and we need to create a therapeutic environment where people feel comfortable reporting their symptoms, right? So I always tell people it's better to let us know, share if you're getting DOT or video dot, that's a daily interaction with the healthcare system. If you're having problems or challenges, let us know, right? And we can talk and think through how we can manage your symptoms better. Treatment shouldn't be miserable, right? Treatment shouldn't be miserable. I do find that the first 2 weeks of therapy can be the most challenging, right? Because people's bodies are getting used to the pills. They're getting used to taking pills. And what's happening is the TB symptoms are still there, but some of the symptoms from the pills are starting. And so I usually tell people the first 2 weeks may be the hardest. And if you can get through that and we can get through that together, treatment's going to get easier over time, right? And also what's happening in those first 2 weeks of therapy is a lot of the TB bacilli are being killed. And so the body has a very robust inflammatory response then as well. So it can just be a really tough time for people. So helping people manage symptoms and thinking through those first couple weeks can be really tough. Any new symptoms, though, that develop after 2 weeks of therapy, we always need to think that that could be a medication side effect. And we need to encourage people to report those to their providers. We need to encourage providers to be open to those kinds of things being reported to them. And then really to think about symptom-directed testing, that if you report symptoms, something should be done about those symptoms, right? When people come in and they tell us there's problems, we need to actively take steps to alleviate those problems and to test for medication side effects. So just very briefly, this is not a webinar where we're going to talk in detail about managing side effects, but if someone comes in with nausea or vomiting, right? Doctors tend to think about side effects drug by drug, right? People who are receiving therapy tend to think about side effects in terms of the side effect that they're having. And so sometimes we think about things a little differently. No one comes into my office and says, I think I'm having a side effect to bedaquiline, right? They come in and they say, I'm vomiting, doctor, or I'm tired, right? And so thinking about symptom-directed management. So in terms of nausea and vomiting, we need to check liver function, test electrolytes, assess hydration status, offer antiemetics, make sure people are adequately hydrated. If someone comes in complaining of fatigue, right, we need to think about, is this a side effect of linezolid, right? Do they have anemia? So testing a complete blood count and making sure they have adequate nutrition, right? There's a lot of food insecurity, and so making sure that people have adequate nutrition is important. Someone comes in and says, my hands and feet are numb or burning, we really need to think about assessing for peripheral neuropathy and then managing that if it's there, lowering the dose of linezolid, making sure people have adequate nutrition. Sometimes people come in with shortness of breath or hemoptysis. We have to check another chest x-ray, make sure there's not anything going on in the lungs. Think about symptom management. Do they need a bronchodilator, et cetera? People who come in with depression or anxiety, or we detect this, thinking about group support, social support. Is this from delaminate if they're on that? Do they need medication like an antidepressant, something along those lines? People come in complaining of chest pain, it's important to always get an ECG, right? We mentioned all those QT prolonging medications. But sometimes people have chest pain from TB pleuritis, and then we can give non-steroidal anti-inflammatories. People may complain of dizziness. It's also always important if someone comes in complaining of dizziness to get an ECG, but also to check them for anemia, get a complete blood count, look at their electrolytes, assess their nutritional status. Rash is common. Any drug can cause rash. And so if someone comes in complaining of a rash, you have to look at the rash. You have to assess them for allergies, other things that might be going on. And then if the rash is diffuse, if it's present everywhere, to think about stopping the medications and serially reintroducing them. We also have to think about when should a drug be discontinued, right? So all of these regimens were tested as whole regimens. If we stop one drug, right, especially if it's one of the core drugs like bedaquiline or the quinolone, right, then the person's going to need to go on an individualized regimen. Linezolid, we're allowed to dose reduce or hold it for short periods of time, but any other drug in those regimens, we need to think, if we stop it, we're going to have to change the treatment regimen. But we really need to balance this. If the person is not able to tolerate this, like, we can't push them, right? We have to find a regimen that works for people. We may need to think about switching between regimens or drug substitution. So sometimes even with these all oral regimens, we need to do this. So just in the last couple minutes that I have left, we thought we would think through a patient scenario. This is common. So let's say the patient or the person coming for care, she's a 32-year-old woman. She was recently diagnosed with rifampin-resistant TB based on expert MTB-RIF. And so when you're thinking about a regimen for her, right, what are some considerations we might need to think about? And she's 32, right? So I think the key here is whether or not she's pregnant. So making sure we get pregnancy testing done, thinking about if she is pregnant or is planning on pregnancy, that we really should be avoiding pratominid, right? And that a regimen for her might be based instead on the beet tuberculosis regimen or on the NTB regimens. But it's also important, maybe she'll say, my husband is working in Russia right now, and if he comes home and finds out I have this, then he might kick me out of the house. We might have struggles in our marriage. So I don't want a clofazimine containing regimen, right? And so she may prefer a 9-month regimen, right? The one of the NTB regimens like bedaquiline, linezolid, moxine, pyrazinamide. She may want a little bit longer on treatment to avoid that clofazimine that's in the beet tuberculosis regimen. So these are just things to think about. Well, let's say she tells you, I had a tubal ligation. I'm not going to become pregnant. So you put her on BPALM. She gets daily video dot, and you tell her, I'm going to see you back in clinic after a month. So what tests should she have done at baseline, right? These are important questions to ask ourselves, right? Probably she's going to be on bedaquiline, pretomanid, linezolid, and moxie, right? So we know she's going to need a baseline ECG, a baseline complete blood count, right? She's going to need baseline vision testing, baseline peripheral neuropathy screening, baseline mental health screening. Right? And then when she comes back in to see you at month 1, we should do all that all over again. And having, again, a checklist, both for her and for you, if you're a provider, can help remind everybody of what should be done. So on her daily B-dot, she's having struggles. The pill burden is hard for her. She doesn't feel well. She tells her nurse, I'm vomiting. Her nurse helps her out there. She might be prescribed antiemetics, but she says, I'm still really short of breath. And when she comes in to see you in clinic, she reports that her vomiting's better, but she is so fatigued. Like she thought treatment was going to help her feel better. She actually feels worse. She's completely fatigued. Right. So it's important what tests should we offer her at this visit in particular to deal with her fatigue. So she needs her ECG, she needs her complete blood count done, her vision testing, her peripheral neuropathy testing, her mental health screening. And you find based on her complete blood count that she has a new anemia. Right. So the results of her assessment show she has anemia. What can we do for her now? So we know that linezolid is most likely the cause of her anemia. And so thinking about maybe holding the linezolid for a short period of time and seeing if the anemia resolves, perhaps lowering the dose. If she was started on 600 milligrams of linezolid, lowering the dose to 300 milligrams is something you might try. In some settings, if her anemia is severe enough, she might benefit from a blood transfusion, right? And then if the anemia doesn't improve or persists, right, then she may need to be switched to an individualized regimen if she can no longer tolerate taking the linezolid, because all of the regimens contain linezolid. So even though they allow for short interruptions or dose reduction, it's important to think about if you need to stop that drug, putting her on an individualized regimen. So my time is up. I could talk about drug-resistant TB for hours, so I apologize for going a little bit over. But I think the key is just there's multiple options now for all oral shorter regimens for drug-resistant TB, and these are available for almost all populations, including children and pregnant people, pregnant women. Adverse events and overlapping toxicities are common, right? And we need a partnership approach with people who are receiving care to optimize management, to minimize those side effects. And then to really think about how we do this in all our populations is crucial because monitoring and managing side effects early will help people stay engaged in care, will make the treatment experience much more tolerable, and will contribute to people having excellent treatment outcomes, which is really a goal that all of us have. So I just want to thank you all for your time and your attention. I'm sorry if I talk too fast. I get excited about drug-resistant TB, so I tend to talk fast. So special thanks, especially to the teams providing the translation. My email address is up here if you ever want to be in touch with me. I love being in touch about drug-resistant TB. And the good thing about Google Translate is if you send me your questions in another language, I can usually get an approximation of what you're looking for or wanting to talk about. So I'm going to stop there. I'm going to stop sharing my screen. And I think now we can go to the discussions and the questions. But thank you again, everyone, for inviting me to be here and for your time and attention today.
Dear Dr. Furin, thank you so much for such interesting and detailed presentation. And I am sure that all our participants found a lot of helpful information there. And of course, we understand that this is topic not for 1 hour, not for 2 hours. So it requires time, but it is good that we gave it a start. I would like to remind you that you will be able to ask all your questions during our Q&A session, which will happen really soon, or you can write your questions in the chat and we will ask them a bit later. And now we are going to have our next session where we will hear about the experience of people with tuberculosis who received the short regimen. And I would like to give the floor to Oksana and Shadman. Thank you, Lesa. And before we show you our short videos, I would like to say a big thank you to Jennifer, because it was so helpful and such a detailed explanation of everything we need to do with our patients. And it is important to have this um, right focus and how doctors need to treat symptoms and how doctors see side effects or adverse events and how patients see them. So it is important for doctors to be really attentive to their patients and listen to them carefully. So we have two short videos with our patients. It was quite challenging because not all people with tuberculosis are ready to speak with open faces. So we say that stigma is lower now, but still people who receive TB treatment, it is hard for them to openly and publicly speak. However, we do see some positive trends, and after I show you the videos, I will comment on that. And now I would like to ask Vlada to start the videos. What is your name? Alexander. My name is Pavel. Alexander. So, do you receive a short treatment regimen now? Yes, I do. And how do you feel? I'm fine. And could you tell me what side effects do you have? How do you feel after you take your medicines? Do you feel sick? Do you have a headache or anything else? No, it's fine. For how long have you been taking your medicines? For a month, for 1 month, right? So you said that for the first 2 weeks, your legs were aching. Do you have any similar side effects now? No, now there is nothing. I feel fine. I'm Igor Mikhailaki, 46 years old, Moldova. So I came for a control visit and I learned about my condition here. Did you have any problems in your family? At home, we eat from one plate. My mother did not know that we had it in our family. She also had a medical checkup. She had an x-ray, but she had nothing. Where did you get your treatment? In Chisinau. And nothing was bothering me there. I feel normal, I think. It's like I already feel different. And on the 1st of October, I came back home and then I went to the hospital to Miss Diana. And then I had all my treatment with Miss Diana. How do you feel now? Well, I had an x-ray. I had all the examinations done, and now I see that after my last visit, I did not receive any further instructions. They said that my treatment was over, so I think it's over. What would you like to say to people who are on treatment now? It is important to take your pills regularly. Regularly. Thank you. Thank you for showing them. But you know, even the short videos for us, it was quite challenging to make them. We are happy that we were able to find people who agreed to speak publicly. What really impressed us and what we wanted to tell you, we see that now there is no special attitude to people with resistant tuberculosis or multi-drug resistant tuberculosis. So now the attitude is changing from the side of the doctors and from the side of patients. So we see these positive changes, that doctors are not focusing on saying that you have drug-resistant tuberculosis, that it is more challenging. So people are told that they can receive their treatment at home. There are some options for where people can start treatment. And doctors do not treat patients differently just because patients have drug-resistant tuberculosis, unlike it was before. And in our country, every fourth patient has drug-resistant tuberculosis. That is why doctors, they basically treat all patients in the same way. And there is no stigma specifically to these patients. There is no different attitude. So all patients, they are treated in terms of communication, in terms of like how they are dealt with, in the same way that everybody else. And what is important to say is that patients who receive treatment now, they do not know that we used to have longer schemes, that it used to be 24 months. So they just know that their treatment is for 6 months, but even 6 months for them, it is a lot. So it is important to support our patients psychologically, and maybe not tell them so much that, you are going to have this kind of short treatment. And this is what we have seen, that now DR TB patients, they are not seen in a different way. Sometimes patients don't even know if they have sensitive TB or if they have drug-resistant TB. So it is good on the one side, because patients, they don't feel that they are some kind of special, and that there is the same approach to everyone. We are happy about that. Thank you.
Thank you, Oksana. We have heard about the live experience of our colleagues from Moldova, and I pass the floor now to Tajikistan. Shadman. Thank you so much. Thank you, Lesya. And before I pass the floor to the patient who's ready to share his story, I would like to express gratitude to Jennifer So thank you so much. Thank you for this very detailed and very clear presentation. That was very helpful, lots of information, and we really value your contribution. Now, next to me, there is a patient who's ready to share his story, but unfortunately, he's going to speak the national language, Tajik, and next to the patient, there is the doctor, Ms. Kushida, and she will help us with translation. So the patient successfully completed short-term 9 months treatment in 2024, right? So now, can you hear us now? We hear you, Shadman, and colleagues. I would like to say that interpretation into English is going to be a bit later, right? The patient will speak Tajik, then we will hear a translation interpretation into Russian, and then we will provide English interpretation, okay? So please go ahead. Hello. I am Ravlech. I had my disease in 2024, and I got a short treatment regimen for 11 months. I was admitted to the hospital with complaints, and after full examination, I was diagnosed with lung TB. After that, I had the impression that the world stopped. Life stopped, world collapsed. Then the doctor explained it to me how it is possible to treat the disease with short-term treatment. After that, the doctor referred me for inpatient stay in the hospital and for treatment. After I started treatment in my family, among my friends and neighbors, I encountered stigma. They started being quite negative. I experienced some negative treatment. However, they explained it to me that with this treatment course, it's possible to be cured. I shouldn't feel despair. So I then focused due to the doctors who explained everything to me. And there were also peer support groups with the patients who already had completed the course of treatment and those who underwent treatment. And they said that it's possible to be cured of the disease if we fully complete the treatment course, if you adhere with the regimen. And I completed full treatment course due to the support, explanations from the doctors and peer support group. They explained it to me that it is possible to be cured of this disease. And my last inpatient hospitalization period was after I took up all of my medication. I passed the required tests, and my tests were positive. And my friend was with me, and that friend passed the message among my neighbors and friends, and he told everyone that I was cured, and then there was no longer stigma in the community. And thanks, I would like to express gratitude to all of my doctors, those who supported me in the course of treatment. I am proud that I am cured now, and that now I am with the staff of the TB service, and I hope that my sharing will be helpful for someone else. I'm always happy to participate in this kind of discussions, to share my experience, to share about my experience of treatment. And also during the treatment, I had 3 kids, but after the course of treatment, now I have a 4th baby, a baby girl. So now he has 4 kids. Thank you. Thank you. Thank you, and congratulations on the new baby. And I would like to express gratitude to everyone who spoke in the session. Thank you for being so open and brave, because this is challenging experience. That's not only about your personal path, but that's an important contribution. So with your presentations, with your sharing, you remind us again about that people with TB, they are not just recipients of services, they are partners in creating efficient system, an efficient system for TB treatment. And me, I am happy to now start Q&A session. And sorry, we are lagging a bit behind, but I believe that everyone who is interested, who would like to clarify some questions, that you're ready to stay a bit longer and ask questions. So you can raise hands and unmute yourselves and ask your questions. And while you're getting ready for that, Dr. Furin, we already had a question in the chat, and I'm ready to read it. After what period of time after PILAM treatment course it is possible to recommend a woman to get pregnant?
Yeah, so this is a great question. So we usually counsel that pregnancy be avoided during treatment. Treatment is complicated, and you know, if it happens, it happens, right? And I think sometimes we forget that people are people, and pregnancies will occur during treatment, and it's not the end of the world if the patient wants to continue that pregnancy. You know, we know there were some patients in the BPALM study, for example, that did become pregnant during treatment, and they went on to have normal, healthy babies. So what we usually tell people is that as soon as treatment is completed, it's fine to go ahead and to plan on a pregnancy. Pratominid is a drug with a very short half-life. And so there's not any need to wait for a longer period of time. So when it's right for the woman and her partner to go ahead with pregnancy, having a history of treatment with Pratominid or the BPALM regimen is fine. There's no long period of time, there's no contraindication to that. So I also saw there was another question about how long after treatment can people expect their side effects to go away? And this is a good question, right? So we often think of TB treatment in terms of how long the bacteria is around in the body, right? But we know that TB can affect any part of the body, and it can cause lasting problems, right? Even if your treatment is over and you're cured. And this is an area in TB that we're thinking about and exploring more, that people refer to as post-TB lung disease. It's kind of like many of us heard about long COVID, right? We heard it, and so I think about it sometimes as long TB. So there can be symptoms that persist after treatment that may have been caused by damages or scarring that TB has left in the body. Then in terms of side effects of medication, it really depends on the side effect, how long after treatment side effects may persist. So I mentioned that early in the course of treatment is when most people have side effects, right? But if some of those side effects are permanent, for example, they may lessen with time, but not completely go away. So let's say someone on linezolid developed peripheral neuropathy, the numbness or the tingling in the hands and the feet, that may persist for months or even years after treatment. And that's why it's important, right, for us to identify side effects early so that they don't become permanent. And then there are some side effects like clofazimine causes that skin hyperpigmentation. And that can persist for several months, even after clofazimine is stopped. And that's because clofazimine accumulates in the fat tissue. So it'll stick around even after you stop taking the tablet because your body has stored the clofazimine away in the fat tissue. The same with bedaquiline, right? Our bodies store bedaquiline in our fat tissue. And even many people with TB are quite thin, but we all still have a little bit of fat around our organs. And so drugs like bedaquiline and clofazimine can stick around for several months after the person stops taking them. With bedaquiline, most people won't notice it. It doesn't usually cause any problems because the level gets lower and lower. But with the clofazimine, because of the skin color changes, and that's very disturbing to people, right? After they stop taking treatment, they're like, why is my skin still a different color? So you just have to counsel people. This is going to stick around for a while. It will eventually go back to what it was before, but it may take several months. So, but other than that, you shouldn't be getting or developing new side effects once treatment has stopped. And if those side effects are identified early, most of them will go away. But that's why that routine monitoring, whether a person has symptoms or not, is really important.
Спасибо большое. У нас есть еще один вопрос в чате.
Thank you so much. We have another question in the chat. So, based on your experience, sorry, wrong channel. So, based on your experience, have you seen relapses after successful completion of short-term treatment?
Yes. So this is something that we do see. It's been reported in all of the studies, right? So we know that one of the challenges with shorter regimens is that there may be increased risk of recurrent TB. So in the studies that were done, most of the recurrent TB rates were around 2 to 5%, right? So quite low, actually much lower than what we saw with the longer regimens. The drugs are great, like in terms of how well they kill TB compared to the older drugs. Bedacoline's great at killing TB, linezolid's great at killing TB, but we know there's going to be recurrent TB or relapse TB. So around 2 to 5%. Those numbers are low, but if you happen to be one of those people, right, it can be very upsetting and very alarming. And so that's why most programs actually recommend routine monitoring even after treatment is complete. So some people say for a year, some people say for 2 years. That you should follow people who've been successfully treated routinely. And that can be as simple as checking in via phone call, but just to say, hey, how are you doing? Are you having any symptoms? Do you want to come in? A lot of countries now, particularly in the region of the world where most of you are working, the rates of TB have gone down, right? And this can be a challenge sometimes, right? Because it's like, well, what do we do with all the staff and the facilities? But making sure that people come in after care is really important. I think we heard from the people who were sharing their experiences, especially our lovely young colleague in Tajikistan. He had a really nice relationship that he formed with his TB providers. And so being able to check in with them routinely, I think would probably be important for him. So that we can identify relapse or recurrence if it happens early and offer treatment for those individuals. So the rates are much lower than for longer regimens, but they do happen. So yeah.
Thank you. I do not see any other questions in the chat or people who raised their hands, but I would like to use this opportunity and ask a question. So based on your experience, you said that people with TB, they come and if they have some adverse events, they do not say that I have vomiting because I received bedaquiline. So in your opinion, which symptoms are overlooked? Like people don't mention it, but it is clinically significant.
Yeah, it's a great question, Lucia. So I think, sometimes people don't feel that healthcare providers will take their symptoms seriously. Or maybe they feel like they want to get in and out of the consultation quickly, or sometimes my patients will say to me, every time I come to see you, you try to give me more medicine, right? And I'm already taking all this medicine, so I don't necessarily want you to prescribe something else for me. So a lot of times people won't report their symptoms. And so I think it's important, again, that providers make that therapeutic space as comfortable as possible and ask people about the symptoms. I think that the symptoms sometimes that people find embarrassing, they won't report. Like I have many young women who stop having their periods. And so they may not tell me about that. And that's important for me to think about with anemia. So yeah, so I ask people from head to toe. That's how I start. Let's start from head to toe. Are you having any problems with the way you're seeing? Are you having any problems where you feel confused or the way that you're thinking? Are you having any problems eating or swallowing? Right? Are you having any problems with nausea or vomiting? And so we sort of go through this head to toe exercise, right? Any problems with how your hands are feeling? Any problems with how your legs are feeling? Any problems with diarrhea? And I just run it head to toe. It's easy for me to remember. And a lot of people are used to thinking that way. So, but it's also why we have to do those standard assessments, right? Even if people don't have symptoms, right? So everybody needs to have their height and weight checked, their height at baseline, but their weight every month. They need to have their ECGs done. They need to have their blood drawn. They need to have vision testing. They need to have the peripheral nerves tested, right? And those need to be done whether there's symptoms or not, because some of it may be it's too early for symptoms, and that's good because we want to catch things early, right? But some of it maybe someone doesn't want to tell me about a symptom that they're having, or they don't feel like they can by checking their lab tests and then following back with the results, right? Hey, we got the results of your complete blood count back. Everything looked fine, right? Can also be nice and reassuring. I also find one thing that I think helps is that when I'm doing an examination of someone is letting them know what I found, right? And if you're someone who's being examined, asking the doctor, how was my exam? So I'll say to someone, I'm listening to your heart right now. It sounds good, right? Or I'm listening to your lungs and I hear an area that sounds a little bit worrisome to me. We are going to get a chest x-ray so we can see what's going on there, right? Just, I think more communication. We have to move away from this place where the doctor's always right. The doctor does things. If person's there, they don't know what's going on. We're partners in this. We're all partners in this. So I think that that's really key, and that the responsibility for that partnership is on both parties, right? But if you're receiving care and you don't feel like there's communication going on, thinking about how you can ask for that or enlist an ally. I often find people receiving care for TB are more comfortable talking to the nurses than me. And while I wish that wasn't true, sometimes I think it's just easier. So I make sure I talk to the nurses that we, like, how is, my patient doing today? And did they tell you anything that you think I need to pay attention to during the visit, right? So the care team, and if you're lucky enough to work in a place that has DRTB counselors, also engaging with them. My counselors, when I worked in South Africa, knew more than anybody. So I would ask them, hey, I'm seeing, Boosie at noon today. Is she doing okay? Right. And so I don't know, just making sure sometimes that consultation room with doctors can be like, yeah, it's quick, it's scary, and nobody talks in there. Or we always have a joke we say is like when my hand is on the door to leave, sometimes the patient will say, oh, I forgot to mention, right? Yeah. So I think just trying to make that space more open. And yeah, it can be hard if you're busy or there's a long line or a long queue, but like that's the most important time that you're going to have together. And so I think maximizing that. So everybody wants the best for the treatment. Everybody wants the best for the person who's undergoing treatment. So making the most of that time together is something we can all do. Thanks.
Thank you so much. I see that Oksana is raising her hand, and I invite you all to ask questions if you have any, because it is your chance to get some answers from a practitioner with a lot of experience. And remember that each question is important. And now I give the floor to Oksana.
Thank you so much, Lisa. I'm just not giving any question because I am aware that we are running out of time. But taking into consideration with Jennifer just now, like the suggestion, because I get it like a suggestion to develop a kind of very friendly questionnaire regarding the symptoms and side adverse events. I would definitely put down together with my team the questions in a way that they are understandable by the patients, and we'll try to run this questionnaire in a very simple way, like, do you have any heartaches or nausea, in the way that people understand, to see how it works. And maybe we can apply it within the country to encourage the reporting of the patients in the way they feel the side effects from their side. Definitely, we will keep in touch with you, Jennifer, and I do acknowledge your great contribution. I know you are a great specialist and one of the not so many practitioners who care so much for people. So thank you so much for this.
And dear colleagues, thank you so much for being so engaged, for your interest in this topic, in this webinar. And of course, we will share all the materials with you. I would like to say thank you again to Dr. Jennifer Furin, to the teams of Moldova and Tajikistan. And I would like to say thank you to our interpreters who helped us to understand each other today. We wish you all a wonderful day or a good evening, maybe, depending on your time zone, and see you soon. Goodbye.